Thanks, James. Could I also invite, in addition to our speakers, David Walker to join the panel discussion? We're running a little bit behind time, but I think we have about a quarter of an hour for discussion. I understand that the audience in the back has had difficulties hearing some of these panel discussions. So could I suggest two things to the panelists? First is when you speak, could you stand up? And secondly, could you speak as closely into the microphone as possible? So there are a number of questions that have already been submitted, but I wonder whether we might benefit from just spending 1 or 2 moments at the outset from reminding ourselves of some kind of foundational issues which are key to this whole linkage endeavor. And Kathy Sudlow, the chief scientist of UK Biobank, might be well placed to address some questions. So Kathy, could you remind us of the consent in relation to health record linkage? And could you walk us through the steps that lead to the production of a de-identified data set to protect confidentiality? We've implicitly referred to those things, but it may be useful to remind ourselves explicitly.
Yes, I can try, and I'll use as non-technical language as I can. So all of you who are participants here, at the time that you were recruited to the study, consented in a number of different ways to various aspects of the study. And one of the very important things that you consented to was to long-term follow-up through linkage to all health-related records, which, as you've heard, is an extremely powerful resource. Now, we don't take that consent lightly, and of course it's very important that in following up through linkage to health-related records, we protect privacy and data security as a very high priority. So when we link to records with data providers, for example, NHS Digital in England or the Information and Statistics Division in Scotland, we share identifiers through a pseudonymizer tool, which means that there's no direct sharing of identifiers, but nonetheless we're able to obtain the information. The information is passed through secure channels back to the database. When it's held in the database, which sits in Oxford, there are very, very few highly trained individuals who have access to the identities of the individuals within the Biobank dataset. We need to know who you are and where you are so that we can get in touch with you, but we need to make sure that very few people have access to that information. Separately is held a database that holds all the information about participants, but none of their personal identifiers. And it's that information that is used for research projects. Does that answer the question?
I think that's helpful. There may be more questions about that. But just on that theme, I understand, actually I just heard in the lunch break that UK Biobank had a recent review of its IT and data security. I wonder whether someone from UK Biobank might want to just briefly summarize the conclusions of that.
So I would have thought that's a question for either Tim Peakman or Mark Effingham if they're in the room. Mark?
That's right, in that we're an ISO 27001 accredited organisation. We had our recent review back in March. So we have a 6-monthly surveillance visit where we have auditors come in. We had no kind of major non-conformances. There's always raised some observations for improvement, very minor ones which we always take on board and look to put in place approaches to improve where necessary.
Thanks very much. So there are some questions already, but I wonder if I want to kick things off with a question from the floor. Maybe while you're thinking of one, I'll start with one of the questions that's come in already. So, James, this may be a question for you. Cancer data gathering looks very thorough. However, we are told that European outcomes are better than those in the UK. What accounts for this difference? What accounts for the difference between cancer outcomes, treatment outcomes presumably, survival outcomes in Europe versus the UK?
So there have been obviously studies that have shown that different outcomes and worse outcomes in the UK. There's quite a few bits of work on that PHE have been supporting. The International Cancer Benchmarking Project has been undertaken, which is pulling data together from quite a few different countries and regions within those countries, and is going to look further to see if they can identify where those differences come from. And PHE have supported that through supplying data into that study. We will hopefully see what the results of that is in the future.
Just a sound check. How is the audibility for the back of the room? So? Good? Good. Okay. Very good. Thanks very much. Questions from the floor? Yes, so there's a question here. While the microphone is coming, could I ask Liam Smith a question? So Liam, one of the items I've been struck with some of your research, which you didn't have a chance to showcase, is the potential value of linking geographical level environmental exposure information with participant information to give insights about the impact of weather, pollution, traffic on health outcomes. Could you comment what particular opportunities and challenges for that might be provided in UK Biobank?
Yeah, so this relates to some work we did linking pollution data and air temperature, that's weather data, to, in particular, we were looking at heart attacks. And we showed quite convincingly that as the weather gets colder, people are more likely to have a heart attack, and as it gets hotter, they're more likely to have a heart attack. With the lowest at around 21 degrees centigrade. It's not often 21 degrees centigrade in the UK, but when it is, that's when you're safest. And we did some work on air pollution data, which was quite interesting because at first we didn't see any effects, and it was only when we linked the little pollution monitors you see dotted around the streets everywhere in the UK, measure pollution every 15 to 30 minutes. It was only when we used the really short-term data that is quite unique to the UK worldwide at the time, we were able to show an effect. And I think it gets into that issue of why people live healthy lives and some people don't. It's a whole combination of things, including things as diverse as the weather, diesel fumes, what they eat, their genetics, whether they go to the doctor, everything. And I think that's the relevance for Biobank, is that it's yet another important strand of why some people get diseases and others don't. Are the things you're exposed to in the environment that you either know about or you don't. So I think it's just really an example of that complexity.
David. By the way, would you like to introduce yourself?
I'm David Walker. I'm a member of the Ethics and Governance Council, and I'm going to make a political point, and you'll forgive me, but it's necessary. The quality of the work that UK Biobank and other colleagues does depend upon levels of public expenditure. Just take that example. There are some local authority areas where air pollution monitoring has declined by 2/3 because of measures taken by local authorities to save money. If you're measuring people's data from GP visits, unfortunately, some people are increasingly finding it difficult to get GP appointments. So I think I'll just make the point that a lot of the quality of the data we're dealing with does depend upon interactions which are themselves the subject of spending decisions, which, let's face it, in recent years have taken a curve towards reduction. Now, I'm not saying that's necessarily going to affect the quality of the project. It won't, but I think it's something to be borne in mind, that we are, in a sense, on a platform which is a platform of public service and public service delivery, and that platform has been sinking a bit in places in recent years.
And these health databases are particularly vulnerable to those kinds of neglect. I think there was a question here. Yes, please.
Yeah, I had a question about the cause of death data, which I'm assuming comes from death certificates.
So could you repeat about what exactly?
The cause of death data.
Cause of death data.
I'm assuming it comes from death certificates, is that right? My memory of when my father died is the death certificate said that he died of pneumonia, but he'd had a major stroke the week before. That was the real cause of death. Are death certificates now more accurate in what they record?
So this is a question that has also come up in one of the written submissions, so we'll bundle that together. So one of the written questions is that the president of the Royal College of Pathologists, Dr. Susie Lishman, told the annual conference of Health Tissue Authority last week that up to 50% of causes of death recorded in death certificates are wrong. How can you be so confident about your conclusions? I'd like to take that. Kathy, Leah?
Yeah, so I think it's a very good question. I'm a clinician. I work in hospital when I'm not doing UK Biobank. So I'm one of the people who has filled in death certificates, both as a junior doctor, when I was perhaps not quite so skilled at doing it, and as a consultant, when I might be more skilled, but also more busy and perhaps not able to give it the attention it deserves. But here we're talking about very large-scale data. So there is some tolerance for error. And that's important. We're not, for individuals, it's really important to get it right. For research, where we're talking about large amounts of data, some small degree of error can be tolerated. And I think the second point is it depends to some extent on the condition, and it depends on how the data are used. So in the case of your father, whose primary cause of death was attributed to pneumonia, even though the underlying cause of death was clearly stroke, the way in which those entries on the death certificate are taken and encoded in the national data sets takes that into account, so that the underlying cause of death is the one that's the primary cause that's used in most analyses, and the other causes are used as secondary. And I guess a third thing to say is that we need to understand and study it better, and that's part of what we're doing in the UK Biobank Outcomes Adjudication Group. So for each of the different major causes of death, we're actually looking for studies in the literature that have studied the accuracy of particular causes of death, and where necessary doing our own small-scale validation studies, a little bit like the ones that you saw Ben showing for some of those diseases, so that for each disease we can tell researchers this is about how accurate these sources of data are. Please take that into account in your research studies.
Thanks, Kathy. So question here at the front, if we could bring the microphone, and while that's happening, questions come through on Twitter about the insurance industry. How can we stop health insurance companies abusing data that donors donated to make UK Biobank possible? So I guess one question of clarification, maybe before Liam answer that, is would UK Biobank regard the insurance industry as a bona fide researcher, because that's a requirement to get data? But Liam, do you want to tackle that question?
Yeah, so I've got children, so I want health insurance. I want life insurance for me, in case I die, not for my benefit, but for my offspring's benefit. And if an insurance company is going to insure somebody, they need to work out how much to charge them, and they need to know how likely it is that 76-year-old men in Britain will die this year, that kind of thing. And they need to know that on a population basis. They don't need to know who those people are. Now, the big worry, and it's an understandable worry, is that an insurance company could criminally, by the way, get hold of someone's individual health record, know who they are, and either refuse them insurance or charge them more or something. Now, that would be against the law, it would be against all medical ethics, and it would be against all sorts of codes of conduct for the insurance companies. So it's important to distinguish this legitimate interest of companies in an insurance company needs to know when people are likely to die. Marks and Spencer's needs to know what sort of people buy cornflakes. They're not that interested in you personally. And for an insurance company to take those sort of steps and hack into people's personal data and that kind of thing, it would be a criminal offence, and it's well worth knowing that and remembering that. Whereas looking at whole populations, and do they need to charge more health insurance, life insurance policy costs? Do they need to charge more in England than Germany because people are more likely to die sooner? That is a legitimate interest. And for that, they need large-scale, what's called kind of tabular or pooled data, where all they're seeing are the summary, what's the average age of death in Britain, that kind of thing. And that's important data. But it's not to be confused with individuals' data, which are private and confidential, and it will be against the law for insurance companies to use it. I'm no apologist for the insurance companies. I don't know anything about them whatsoever. All I know is that I can see why they're interested in group data, and any interest in individual data would be definitely against the law.
Thanks, Liam. Yes, in the front.
Okay. I used to work in the NHS in public health, and after the totally unnecessary and wasteful and ridiculous NHS reorganisation in 2012-2013, undertaking the sorts of routine analyses of data that I'd been able to do with colleagues quite easily. And I was working then in a primary care trust, which later became a CCG. After those changes were introduced, it all went to pot. We just couldn't analyse things in the way that we had before. We couldn't get data downloads in the way that we had before. And I just wondered whether those changes impacted on your work in a sort of a damaging kind of a way, or were you above it, sort of thing?
Yes, I mean, so those changes probably have made life difficult. I'm pleased to say I come from Scotland, where we still have a proper NHS with health boards, and we don't have devolved healthcare in quite the same way as in England, but maybe that's a rather contentious thing to say. But Scotland is quite small in biobank terms, and England is where we operate. It's still the case that those national data sets are held nationally and returned by all the hospitals, even though they've been structured in a somewhat different way following the health reforms. It is difficult to interact with NHS Digital and obtain data at national scale in a smooth and cost-effective and efficient way. I'm not aware of how much there has been a change before and after the health forms in terms of any kind of measures of it at national scale, but I do know that it's been difficult and slow, but that Biobank has, through tenacity and belligerence, been able to navigate its way through a path to linking to those data, and other large studies have been able to benefit from that. So all is not lost.
Yes.
I wouldn't.
Final word.
It wouldn't diminish in any way your criticism of the Lansley Act, but it could be. I mean, I was just sitting here this afternoon thinking of all the ways in which biobank data might be linked with other data. Local authorities do have primary responsibility in England for the delivery of social care. Wouldn't it be very interesting to see how people's pathways in and out of social care might be linked in whatever way with their disease etiologies? And so, I mean, you're absolutely right about public health problems, but in local government there is a massive, potentially hugely fascinating data there, which maybe ideally at some point might be linkable.
So I'm afraid we're out of time. I'd like you to join me in thanking our speakers and panelists for a stimulating session that highlights how this large-scale phenotyping using records really is yet another frontier that UK Biobank is trailblazing. So thank you. So we're going to move seamlessly on to the next session, which is going to be chaired by Professor Paul Matthews from Imperial College, who chairs the UK Biobank Imaging Working Group.